quite reassuring to patients to have the visiting nurses come.
Well, I'm going to share with you an interesting, well, interesting from my point. I mean, it was just an anecdote. Many years ago, I was involved. I was riding my bicycle and I got hit by a van.
Oh no!
And I was in the hospital. I had some surgery done to repair my arm. My hospital stay was great. I was in the hospital, I think, maybe 2 days, maybe 3 days. I can't remember. It was a while ago. But when I left the hospital, I was like, you know, I'm okay. I mean, I'm fine. My arm's fine. You know. But when I got home, I was like, oh my gosh. I couldn't do anything.
Yeah.
You know what I mean? I mean, showering, you know, getting dressed. My arm was in a sling. My arm was in a cast. You know, the idea that there could have been a physical therapist or an occupational therapist at my home, because I think when you're in the hospital, not only are you, like you were saying, sort of preoccupied with all of these things that are going on, you know, certainly no small measure just the illness itself, but I don't think you really think about, okay, well, once I get home,
Right.
what's it going to be like? Because once you're home, like you were saying, you know, there are stairs, there are these things that you simply aren't dealing with when you're in the hospital.
Right. Pill bottles to open.
Right, and stuff like that. And if you have limited mobility, or if your arm, like mine was really, I basically had one hand for a few weeks. You know, it was really overwhelming, and the sort of magnitude of my injury didn't actually hit home until I got home, and then I was like, oh my gosh, this was really a bad, you know what I mean?
Sure.
And so it's interesting to me, because I do think that that's an important part of what you know, the patients go through, is because sometimes they don't even realize what the importance of that home health care visit might be, because they haven't gotten home to realize what it's really going to be. But when there are these referrals, and when you are made aware that someone is going to be perhaps getting VNA services at home, do you meet with the patients in the hospital?
We try to. Sometimes the patient is asleep. I never wake anybody up who's asleep. I figure they need their rest more than anything. Or they may be occupied with therapy. The physician may be in there. We do try to meet with everybody briefly to just go over what it is that home care means and payment for it. And if we do call people the next day. So if we have not had the opportunity to meet with them in the hospital, then the office does call either the supervisor or the clinician scheduling the visit, or somebody from the intake office will give them a call to say, we received your referral. Sometimes people get home and actually say, you know, this isn't as bad as I thought it was. I don't think I need you. Other times people get home and say, when can you come? So it you know, that matters. Typically we get out to see people within that day or the next. Get them started out with some home care.
Yep, and that's I won't get into detail on that right now, but that's basically the admission. That's when we admit them to services at the VNA. So you touched on this a little bit, but perhaps we can maybe this is a good time to sort of segue. When I do get home, maybe you could help us explain to our viewers what is the goal of home care? And then also, you know, sort of tied to that, you know, what can I expect from home care when I'm being visited by a therapist or a nurse in my home?
Well, the goal from our perspective of home care is to get someone back to a more independent level of function. For instance, if somebody's had a stroke, they may not get back to exactly the way they were, but to get them back to as good as we can get them, so that they can then begin participating in the community. If they have a wound, our goal is to heal the wound. If they have a new diabetes, our goal is to educate them as much as we can to be independent with that. So those are our goals, but more importantly is what the patient's goals are. And after someone is home, depending on who the physician has ordered to go in, the first visit could be by a nurse. Some people don't need nursing at all. Someone who has had a joint replacement who doesn't have a lot of other things going on will only have therapy at home. But that first visit, the clinician will Sadly, there's a ton of paperwork that has to be done, but that's the Medicare regulation,
Yes.
and we are a Medicare agency,
Yes.
so we have to follow that for everyone.
Yes.
So there's a lot of paperwork. The clinician will do a complete assessment of the patient, and then we'll sit down and with the patient come up with some goals.
Yep.
How about if we try to have you be able to walk across the room by my third visit?
Right.
And, here's what and so we found that if the patient is not interested in what we have to offer, then we need to try to find some goals to come
Yes.
up with. So we try to have the patient actually driving the show. We are in the home to assist people, and we are there to help them, but they have to have some buy-in and some responsibility. So, and families as well. We're more than happy to have families come and visit, talk with families on the phone if the patient gives us the permission to do that.
Yep.
Again, with the goal of getting them as independent as we possibly can, and then resuming being out in the community.
Yeah,
So-
and again, I think, I think it's important for folks to understand how important their role is, because really the goals of the plans of care, while clearly medically based, are really, it's really, myself as the patient and you as the
Sure.
clinician coming up with these things. And I am very much, as the patient, involved in the goals of my plan
Right,
of care.
right.
Because a big piece of it is getting me back to a level of functioning that is consistent with my views of sort of my quality of my life.
Exactly. And that's a little bit of a change, because when you think about our grandparents and some of our parents,
Yeah.
they would become ill, they'd go to the doctor would tell them what to do, and they would go home and do it.
Yeah.
And they never really participated except to follow the doctor's
Yeah.
orders. Well, now I think there's been a huge shift in people realizing that they can have quite an impact on their health care.
Absolutely.
The internet is just full of different, some helpful, some unhelpful
Yeah.
information. So I think that people have changed. People do want to have more responsibility. And that's where, again, the visiting nurses can be very, very helpful
Yeah.
at sort of helping people clarify their goals, helping people move forward with them. And, I think it's a good program that way, too.
Now, you had said a moment ago, and I think it's worth exploring a tiny bit more, because I think that it's one of those areas that is not always commonly understood. You said, about the paperwork and the fact that we're a Medicare, CMS, Medicare, Medicaid certified agency. If someone is prescribed home health care, like, say, for the sake of argument, through RAVNA, it's not 24 hours a day, 7 days a week,
Correct.
is it?
Correct.
And not everybody is actually eligible for receiving home care,
That's-
like for the
right.
sake of argument, under Medicare
Right.
or Medicaid.
Right.
Is that fair?
That is fair. First of all, home health care is called intermittent care. It is not meant to be 24-hour care. And that's where I was talking about the person who is ready to leave the hospital but is not able to be independent
Yep.
enough to not have home care, and family, for instance, may not be available. So it's intermittent care, and I don't know of any insurance company that pays for 24-hour care. So
Right.
beyond Medicare, Medicaid, the private
Right.
insurance companies as well.
Right.
The Medicare guidelines for home care are, they've been the same since 1964, and so I know them well. People need to be, first of all, under a physician's care.
Right.
And we have to go in with physician's orders.
Yeah.
In order for us to bill Medicare for it,
Right.
which is their health insurance.
Yep.
They need to be what's called homebound, and I can talk about that a little bit.
Sure.
And there needs to be what's called a skilled need.
Okay.
So skilled need
Yeah.
simply means
Yeah.
that a skilled need is someone is tasks that people have been educated to do that the typical layperson will not know how to do. In other words, I went to school to become a nurse,
Yes.
physical therapist.
Yeah.
And while we can teach patients very complex tasks,
Yeah.
the typical layperson would not be expected to know that.
Right.
Your elbow is the perfect example.
Yes.
You get home and said, whoa.
What do
now
I do?
what?
Right,
Now
absolutely.
What? Now
That's
where do
absolutely
I go?
what happened.
And and so often when I'm working in the hospital, I try to think of like a layperson. I try
Yeah.
to say to myself, I've just had my gallbladder out. I'm on all these pain medications. I feel really rotten. yes, a few home care visits would be helpful to somebody like
yeah,
that.
because again, I think you don't even know what you don't know.
Exactly. Exactly. Until you get home
Right.
and then you try something,
Right, and you
or
have to
you would
wait.
think, gee, can I eat this?
Right.
Or
Yeah.
do I take this pill alone? Or
Right.
there are all kinds of things that come up.
Yeah.
So, and then the other issue is homebound,
Yeah.
and that's a huge thing. It's a Medicare regulation, so it's a federal regulation for
Mm-hmm.
home care. Many private insurance companies also follow the Medicare homebound regulations.
Yep.
So, and basically what it says is that you do not leave your home frequently. Your time away from home is infrequent, it's short duration, and it's with taxing effort. So in
Right.
other words, somebody comes and helps you out of the house, into the car, and drives you somewhere. And you're not going out every day. You know,
Right.
it's medical care does not count. So if
Right.
you're getting dialysis 3
Right.
times a week, if you're going to radiation therapy every single day, you can still be considered homebound.
Yep.
But you're also pretty wiped out by those
Right,
things.
right.
So it's,
and there's
it's
also
difficult.
still going to be some skilled
Right,
care
and you're
associated with that.
receiving medical care.
Right,
Yes.
right.
So, it's kind of a gray area. The wording is very vague, and what we do is we look at every case individually to try to determine whether we think somebody's homebound.
And that's really what the intake process
Yes,
is really about.
that's one
I
of the
mean,
things that the case managers and the physicians at the hospital are also very savvy about what
Right,
homebound means.
Right. But that's part of the analysis of
Exactly.
can this be? Because
Yes.
again, if Medicare, which maybe this is a good sort of segue for that too. I mean, the way that home care services are paid for, the primary methods are Medicare or Medicaid.
Yes,
Right.
the majority of our patients are Medicare, Medicaid.
And which
yes.
means if Medicare or Medicaid are paying for it, then not only do the patients have to meet the eligibility requirements for Medicare and Medicaid to pay for them, but what they need has to meet the Medicare
Yes.
requirements in order
Yes.
for us to be able to provide those services.
Exactly, yes. Yeah, there has to be a skilled need.
Right.
They have to be homebound. It has to be intermittent care
And
versus 24-hour care.
all three of those have, it's
Yes.
not an either or.
Right. And the other thing about homebound is people say, well, I want the visiting nurses to come, so I'm going to stay home. No.
Right.
You are either homebound or you're not.
Right.
Now, it could be that, yes, you are able to get out of your house without a taxing effort. You are able to drive your car. But your physician has said, while you are recovering from this,
Yep.
or whatever this infection you have, I want you to stay home.
Yep.
You are then homebound because you are medically homebound by the physician.
Which again is
So-
part of the process of that you
Exactly.
go through, part of the process that the case managers go through in assessing whether or not a person
Right.
could benefit from home
Yes,
health care services
yes,
after hospitalization.
Yes, yeah. So when we get the name at the hospital,
Yep.
or at our office, because we get quite a few referrals, from other hospitals that come into the office, and that's what we look at. We look at what their needs are. We look at whether or not we think these needs are something that can be provided at home. We look at what their insurance is and whether they meet the criteria for that. So
Yep.
there's a whole bunch of things that we look at before we actually may even go talk to the patient, just to
So
see
it
if
would
they
not- sorry.
qualify.
So it would not be unusual then for a new potential home care patient, client, to be asked a series of questions by, say, somebody like yourself.
Yes.
Right?
Right.
And again, and the reason for that is because we need to determine how that person can and under what circumstances they'd be eligible to receive home care services.
Exactly.
Okay, that makes a lot of sense.
Yeah.
So we focused on getting home care after leaving a healthcare facility, but other than a stay in the hospital with a referral to home care at discharge, what are some of the other circumstances when home care might be appropriate?
And actually, we get several referrals through the office from people who have not been in the hospital, or people who have. We got 2 this morning. One, somebody who was in the hospital a while ago is struggling mightily at home. They're not coming around. They're not feeling well. Physician said, "Can you go see what's going on with them?" We got another referral this morning, someone who was recently in the emergency room and was sent home from the emergency room, same thing. They are having a terrible time at home. So